Okay, getting huge feedback. I have to mute all the phones. I'll mute mine for now. Tell me when you're ready.
Okay, I will. As a point of clarification, if at your clinic, if you have physicians who are attending this meeting and they want CME, could you please send their names to Dale Michaels, CMO at SERPA-ACO.org. Again, if you have physicians who want credit for this, we're offering one hour of CME. So please send the physicians' names to Dale at CMO at SERPA-ACO.org.
Yes, sir. Take care. Thanks for stopping down. Okay, you do that. Yeah.
What is his name?
Chuck O'Donnell.
Oh, yeah.
Yep.
Right.
But you mine? Nope.
We were harassing each other in Russ's Sunday morning.
Oh, okay. Yeah.
We have about a minute before we get started today. Couple of points. If you can put your phone on mute and it's not music, please do so. We get so much feedback. If you do have music, don't put your phone on mute or on hold or whatever. Also, if you have physicians who want medical education CME for this, please write their names down and send those names to Dale at cmo@serpa-aco.org. And if you forget his, you can always send them to me and I'll forward them on to him. And so we have just a little bit of time here. It looks like it is 12 o'clock. So we will let Dr. Mills get started. And we will be recording this, hopefully for use to put out on the YouTube. So Dr. Mills, it is all yours.
Great. Thanks so much, Jolene and Dale and SERPA. Thanks for welcoming me back for this month. Sorry that spring break schedules got in the way of last month. Excited to continue our conversation. I really enjoyed meeting many of you in person at the meeting. That was a really neat venue, and if I'm ever traveling past that way again, which might happen, I look forward to stopping in there. So let's piggyback on what we discussed in person, which was a drink from a fire hose view of MACRA and MIPS, to narrow it in even a bit more and say, okay, so you're a SERPA-ACO provider. What do you do now? What do you focus on? And that's what we're going to spend the next hour talking about.
Get that one.
So here are some CME obligatory slides that it is in. Appreciate the Interstate Postgraduate Medical Association, SERPA, sponsoring the CME. You heard the prior announcements about that. There are no relevant disclosures or commercial support for this activity. I'm glad to see Don Clickguard was a reviewer for the CME provider. He's a good friend and a great doc, so glad he was involved. So as we think back to our experience together into this month, we're again faced with the reality that, we might be a place we didn't intend to be. But here we are. We have a bridge, a beautifully built bridge or healthcare system that didn't anymore go where it needed to go. So there's a proposal, this quality payment program for Medicare, to get us back across the river. And today is how we help construct that new span to get where we really want to get together. So our agenda is to kind of clarify, and I'll talk about it a little bit and answer questions, clarify the interrelationship between MSSP, patient-centered medical home, and MIPS, Quality Payment Program. We'll review the advancing care information in detail, and we'll really spend the last portion focusing in on how SERPA-ACO and all the affiliated clinics and providers can work together to simplify the data, the quality, and the reporting, and to really have a wonderful opportunity to maximize your composite quality score and your performance score, and to maximize moving forward the bonus that you get under the physician fee schedule. So just a bit, I continue to get questions, and this is something that has to be touched on again because it is complex, but let's just briefly recap the time we had together, which is to say, so we know that the healthcare system, focusing in on the triple aim, we need to improve our care, reduce the cost, and improve the experience of all of us involved in the care system, both providers and patients. That is focused in really on, from Medicare's perspective, on aligning incentives, not just paying a transactional fee for service anymore, improving care delivery, and improving our response to data and data sharing throughout the healthcare ecology in the country. We do know that in this, Medicare is driving the bus. So unlike other times in other places that innovation filtered from private industry into the government, right now Medicare is driving the conversation towards better quality and cost in healthcare, and that is proving they're doing it quite effectively. That effort is being run through the Innovation Center, whose purpose is to test and innovate payment and service delivery models to improve quality and reduce costs. And like I said, that is working. The CMI Center is also the part of Medicare that is sponsoring CPC Classic and now CPC Plus, which we'll have further conversation about probably at a later time. Some note here, so this was funded under the Affordable Care Act. All current, commentators and policy watchers, including the AAFP and the AOA health policy experts in Washington, D.C., say even if the ACA is partly rolled back or repealed and replaced, we do not expect that the funding for the CMMI Innovation Center or most of the current projects will be terminated. So this really is probably our way moving forward. The pace may change, but the structures that are built and proven successful won't get just unilaterally erased. That track is to, over a very quick period of time, reduce from 100% to 10% or less the amount of total dollars Medicare spends, which is purely transactional fee for service, and over the same period of time to dramatically ramp up the connection to value-based or outcome, so that some connection goes up to 90+% and a tight connection to total cost of care or proven value, that being, of course, quality divided by cost in a sense, goes up to at least 50%. And this has tipped over faster. So in 2011, Medicare made this prediction. That was their goal. Actually, it tipped over, in 16, well before we get to now. So the macro legislation did a couple of important things that we all wanted in general, which is to repeal the SGR, to extend CHIP funding for 2 years. I think that was a throw-in. It provided a fee-for-service baseline update, 2016 and 18. Remember, for multiple years as a bargain to punt the SGR refiguring down the road. The House of Medicine made a political argument essentially saying if you will, you will ignore the SGR reset and move it to next year, we'll accept a 0% update. And that had gone on for quite a number of years. So for these 3 years, 16, 17, 18, there was a baseline update, modest, and then it sets a 5-year pause while MIPS stands up. So the MACRA established these 2 payment pathways, MIPS and the APMs, consolidated a whole variety of Medicare quality and value programs which had duplicative reporting, different definitions, the measure sets were slightly different. It was really a bit of a mess, and so it rolled meaningful use, PQRS, and the value-based payment modifier all into one program, and that's something we very much wanted. So then you look forward and say, well, okay, so it makes all of those things rolled up into a composite performance score. PQRS is squarely the quality component. Meaningful use is squarely the advancing care information component of MIPS. Value-based modifier was part quality and part resource use or cost. And then there's this 4th category that really isn't tied to one of those 3 programs that got folded into the batter here, and that's a comprehensive primary care, or CPC-like, focus on practice improvement activities. So in MSSP, each site and SERPA as a whole may have done some of these activities. CPC focused in more specifically on how the methodology of how you do a PDSA, how do you respond to data in practice, and how do you change your culture so that's how you provide care every day. And MIPS brings that idea into the fold, makes it kind of the fourth pillar of MIPS. So MACRA was the legislation, MIPS was the payment track, and then the quality payment program is how Medicare is administering this moving forward. So moving forward for this year, there's 4 options. They really set a very, very low bar for all of us, which is to say, if you'll at least test, if you'll submit a tiny amount of data on one measure, you'll just test your IT hookup, Medicare will guarantee you don't get a negative adjustment, you stay at 0. That's the first layer. If you do nothing, if you don't respond, don't submit anything, you get the maximum negative penalty of minus 4%, I believe. If you test and send something about something, you're guaranteed a 0. So a larger clinic, an organization like SERPA with informatics and IT professionals helping out won't probably need to use this very low initial bar. But a small practice with challenged resources and an EHR vendor that's not upgrading things on time, this is a really good tool to just guarantee you don't take a loss. Partial participation is you report a minimum number of things for 90 days. That gets you some small positive, probably between 0 and 1%, 0.2%, something like that. If you do full participation for every measure for at least 90 days up to the whole year, you're guaranteed a modest or a moderate positive adjustment. And then if you hit it out of the park and submit all data for a whole year, you might qualify for all the way up to the full 4% bonus adjustment. So a whole spread of options, a very low bar for engagement just this year. So the MIPS payment adjustment, this is just a schema. You see that this year this year's data that we submit is adjudicated and reported back by mid to late 18, and then that sets our fee schedule update for Medicare in 2019 up to +4, -4. We know that the vast majority are going to be 0 to a very small percentage. So this shows you that if you have greater than 70 points, they're anticipating you'll get a positive adjustment and be eligible for the bonus. So $500 million of new money put into those who perform exceptionally in 2019 based on 17 data, get more than 70 points in your composite score. The vast majority of performers are expected to be in the 4 to 69 points, which will be some small update, and then that will be the majority of performers. If there's at least 3 points, that gives you a neutral update, and then if you do nothing and turn in nothing, you get the maximum negative. So here's what that looks like on a curve, just for it's interesting to just think how points will land on a curve, and it will update each year at a much higher slope. But that's a review of enabling legislation, MACRA, described as a payment pathway MIPS. The second payment pathway is advanced payment methodology, and then rolled into the quality payment program and how it's going to work. So let's focus in a bit on how does this impact SERPA-ACO. So first of all, there's your 4 pieces, right? Quality, cost, CPIA, improvement activities, and advancing care information, or ACI. And I'm going to say this a couple of different ways because I think this is maybe one of the 2 or 3 key take-home messages today. Your quality is 50%, since you're in MSSP, track 1, for MIPS data this year, right now, for 2019 payment update, your quality score is 50% of your composite. It is based not on MIPS quality definitions, but on your already known and understood ACO quality measures that you have been reporting now already for quite some time. And that reporting will be done for the entire group by SERPA using the group reporting interface. So that is essentially exactly what SERPA did for the group on the phone last year. So that's not different. Your cost, that's off the table. Since you're in MSSP, cost is not counted for you this year. It's waived for 2017. And probably we anticipate most watchers think it'll be waived for 2018, but that's not yet a sure thing. The reporting for that, even if it was present this year for us, it would be figured from CMS administrative data. There would be no reporting burden on any providers or on SERPA. But it's waived. Ignore it completely. The improvement activities, that's 20% of your score. As you're participating in an MSSP, you get, quote, full credit for this component. And that is automatic. CMS will do something administrative that says you get full and entire credit automatically. There's no reporting for it. That's if you're in regular MIPS, you don't get that. If you're in MSSP, track 1, so you didn't qualify as a qualified APM, but you get very preferential scoring. And part of that under MIPS is automatic full credit for improvement activities. The conception being that in the MSSP, you are already doing things to improve your quality. And we know that is true. And they're essentially saying, we accept what you've been doing, we give you full credit for that up front. No word at this point on how long that particular stance will last, at least this first year or 2, I would imagine. So ACI, Advancing Care Information, 30% of your composite score. That is on our plate, and that is scored as a whole at the SERPA-10 level. So each individual will contribute. Each site then contributes their summation. That's all rolled up together under the SERPA tax ID number. So SERPA will roll it all up, report one score for the group. There's some options in how SERPA reports that to Medicare on behalf of the group. My suggestion, and I think the logical recommendation, is to report it through the group interface, and we'll examine that a little bit more coming up. So we've already talked about those key points. So for this year, all you're really paying attention to are the ACO quality measures and advancing care information. This is another way to look at it. You're the second column, MSSP. So ACO quality measures, the performance improvement is the second way to look at it. Performance improvement, you get an automatic, we think, 30 points. That says 20%, but it's actually 30% and for CPIA, and then the ACI is the piece that's left. So next, the question is, people have to think about, are you reporting as an individual or a group? And I want to say, just the individual reporting, if you belong to an MSSP, is not an option for you. The group will report at the group level through the SERPA-10 for everybody. And so that's already decided by you being part of an MSSP. We throw around the term GPRO, the group practice reporting option. I just wanted to briefly define that for people, which I find among my partners little visibility or insight to what that means. So that's the group practice reporting option is a reporting web interface. It's basically a reporting website that you go to, and then you enter your tax ID, you enter all your identifying information, and then you essentially by hand put it from an IT or an EHR report, you put in your numbers or import numbers, and then submit to Medicare, and that's how they receive the data. GPRO has been what has been used for MSSPs to report the quality data for, as long as MSSP program has been around. The interface has improved, but it's always been there. Secondly, physician quality reporting system is reported under GPRO. PQRS has sunsetted and got folded into MIPS, of course, but most groups, so the SERPA-ACO did the quality reporting for you, but most of the groups on the phone should have been reporting PQRS data through the GPRO at your clinic site level by provider. And so you would have some insight to what the GPRO looks like. So I said there's some options, and this is how MIPS data can get to Medicare. So those top four are really the ones that make the most sense because it's the ones that could cover everything. I've highlighted, you're just paying attention, remember, to quality and ACI. You get automatic full credit, 100% for the CPIA, and the web interface would let you report both of those. So it is possible that you could do it through a qualified clinical data registry or a qualified registry. Those are subtly different. I'm not sure those are accepted, however, for the quality reporting. I think that has to be through the registry for them, through GPRO for an MSSP. And it just seems to make sense to not have to hire another vendor to run the qualified registry. You may have a relationship that can do that, but reporting it both through the GPRO is an option. Another option, if you already have a relationship, is to use a qualified clinical data registry or qualified registry to report your ACI if you choose to. Those are, I would think, decisions that SERPA leadership, Dale and Jolene, would make with input from the group. So remember that we're assigning points based on deciles. So for each measure, you get a score. Each score then gives you a number of points, and then that adds up. I will have examples that make that more clear. But realize this is for the whole group. Every individual's points for ACI are counted all together. At the SERPA-10 level, you'll have so many points in the numerator out of, so many points total, and they'll put that on a chart and say, well, that means we got, 60 62%, and then that in turn that adds up to the 30%. Basically 0.3 times however many points you get is your ACI contribution. So there'll be some math that will be more clear coming up. And that's just showing the grand scheme. Each MIPS entity, each provider or clinician submits data for each of the parts you're responsible for, in this case just quality and ACI. That's added up to a category score, so you'll have a quality score for the group and an ACI score for the group, and then your automatic 20 points for CPIA. Those three add up to get you a composite score, the number 3 box. That composite score is added up to what the performance threshold is, and then put on that scale to say what your adjustment is. So that's how it all works. Let's look at that again, starting with this. And I mentioned I was going to touch on this a couple of different ways. Resource use is off the table. We're not worrying about it at all. The practice improvement activities, you get full credit. That's an automatic 20 points. You're not worrying about that at all. That stuff you're already doing that they're going to give automatic credit. Your quality is the ACO measures you already know and love. So just check the box. It's done. So all of really the group's effort, moving forward into MIPS, as long as you're in MSSP Track 1, is on advancing care information. So let's look at that category. Here's the front slide I mentioned when I was with you in Nebraska. So this is the Quality Payment Program website, and there's the web link. You see there's tabs across the top for the 4 different components that make up your composite score. It gives you a good introduction, and then it lets you look at any given measure. So this is the base measure looking at e-prescribing, and then open up the description. So you see that e-prescribing talks about at least one permissible prescription written by a MIPS eligible clinician, yada yada. So the website is very flexible to use at team meetings or clinic site meetings just to better understand what this category is. The whole QPP website actually is quite good. Lets you download all the stuff as an Excel file and manipulate it if you need to. In reporting, there is some flexibility, and I've had some questions from a variety of venues saying, well, maybe I don't have to report this year. So there is flexibility if you're a hospital-based clinician. So if you're an anesthesiologist or if you're a hospitalist, ACI is not expected to be reported. They just divide up your points among the other categories you can't report. Well, that's not anybody on the call. If you're a clinician who's 100% administrative and you never see a patient, well, then you as an individual won't have any ACI points. That doesn't mean your group won't have ACI points, though. For this year, if you're an NP, PA, nurse specialist, or registered nurse anesthetist, you won't have ACI. Okay, we get that. Again, nobody on the call. Lastly, if you can prove that you have, quote, significant hardship, no definition of how that will be adjudicated. If you can prove that you have no possible internet access, meaning you can't report, or through no fault of your own, and there's been some chatter on the CMS help site, through no fault of your own, and you can prove that you've strenuously worked to get the upgrade, your EHR technology is not upgraded or unable to produce the reports, then you can petition to have your ACI not counted for this year. That isn't anybody on the call. Those are kind of off the table. So every clinic and every provider in SERPA will be reporting ACI, unless there may be a unique circumstance I'm not aware of, but I don't think any of that would account for us. So to get possibility of your bonus, we need to fulfill these measures for a minimum of 90 days. And there's 2 different options of which measure set. So ACI essentially has 2 different definitions that we'll come up to. There's some bonus credit, and here's how it adds up. So advancing care information is composed of a base score, 50%, 50 points. It's really better to think of it as points, not percent, because when you look at those percentages, they quickly add up to more than 100%, right? So in my mind, percent always means out of 100. That's not quite how Medicare refers to it. I substitute points, and that makes it more understandable. The base score, which is mandated, is 50 points. There's a performance score, which is either 60 points or 90 points, depending on which measure set you use. And then there's bonus score of up to 15 points. Now, ACI is scored out of a 100-point maximum, and yet there's either 155 or 125 points possible depending on which measure set you use. So this is like school. This is like an AP test. 100 points possible, but it's graded on a curve, and there are actually 125 points on the test, right? You can miss the first 25 and still get 100%. So that's the way to think of it. It is, again, in a sense, lowering the bar, or another way to look at it, making it more flexible, that you can choose the categories of the things you feel really good about, highest score, or you can do more, more moderate performance on a higher number of things and still get close to that magical 100-point total. So I mentioned two different measure sets. Let's look at that two different ways, and I'll have a recommendation for the group. So there's the 2015 Certified EHR Technology, or there's a 2014 Certified EHR Technology. When I say there's two different measures, it's based on your EHR edition. In a sense, the EHR edition is different for every EHR, and then if there's multiple clinics inside SERPA that all are using Allscripts or Epic or EMDs, it actually depends on where your upgrade is with your actual product, okay? So that could be so one way to handle this would be a really hellacious spreadsheet of every EHR used inside SERPA and which certified EHR version they're on. And if they're on 14, what's the upgrade schedule where the vendor can guarantee they're going to be at 15, right? Well, the words EHR vendor and guarantee really don't belong in the same sentence. Looking at the 2014 Certified EHR set, that is the only one that you can use if you're only on 14, right? It also has some flexibility or some better options in the measures. And what I mean is that measure you see in the 2015, the Advancing Care Information Objectives and Measures, white boxes on the left-hand side, the send a summary of care, that means not we put it on a fax machine and faxed it, and that doesn't mean we actually pushed a CCD to an HIE. That means my EHR electronically sent a summary of care to someone else's EHR. I don't know about you, but right now at St. John Health System, we're in a 2014 version, CERT version of Cerner, upgrading to the 15 version. Even the 15 version can't do that. The request and accept a summary of care. That means you can electronically request. For my EHR, I request of Dale's EHR that he send me a summary of care, and I can receive it and import it to the record electronically. My EHR can't do that yet. I don't know of any that can. Same thing with the secure messaging, as well as the patient-generated health data. That means the patient can sign into the portal or into your EHR, and through that electronic connection directly provide health information to their health record. Again, that's not possible through most EHRs, and those two that are the base measure for the 15 certified version, those are required. You would have to be able to do that or you get a 0. So my strong recommendation, which I've discussed with Jolene and Dale, is that the group use the second option called the 2017 ACI Transition Objectives and Measures. It makes me a little bit crazy. They named them so similarly. They both ACI Objectives and Measures. Just in your head think 2017 Transition Measures. That does make you think that maybe that won't be an option for 18 or for 19 sometime in the future, and that's probably true. They're a little bit easier to use with current technology, and if a substantial portion of your group is at the 2014 certified EHR version, that's really the only option. So that's a SERPA leadership decision, but that's my strong suggestion, is that everybody focus on just the transition objectives and measures. Right, and I will say that's not a clinic-by-clinic decision. That is a SERPA has to report the same set for everybody in SERPA. So then let's dive down and say, okay, we've talked about that there were base measures and performance measures. And you remember we talked about the base measures, 50 points, the performance measures. If you count those up under the 2017 transition objectives, you see 4 base measures instead of 5 on the left, and you see 6 performance measures instead of 9 on the left. So the base measures are worth 50 points. The performance measures are worth 10 points apiece. That's where you get 60 points, whereas on the left it was 90 points. So let's look at the base measures. So the base measures, I'm going to focus just on the 2017 transition objectives. So it's security, and you notice they line up. The first 4 are the same in both columns. Security risk analysis, e-prescribing, provide patient access, and health information exchange. Those are the 4. This is the base score, the 50 points, is an all or nothing. You meet all 4 of those and get 50 points. You do not meet a single one of those and you get 0. When you look at the far right-hand column, required scoring, you see that one of these, security risk analysis, that's simply an attestation. That means when you're pulling up GPro, you simply attest, yes, you did the security risk analysis. And we'll get to that a bit more in a minute. The other 3, it's simply you have to have some number greater than 0, and I swear this is how it's defined. It's not a numerator denominator. For each of those 3 measures, and they have a definition, you simply have to have something. You'll have a denominator that your EHR spits out, and then you'll provide that data to SERPA. No matter what the denominator is, you simply, for the entire SERPA 10, have to have something greater than 0 in the numerator. So if one provider in one clinic does each of those, and there's a 1 in the numerator, you can report and you'll get your base score. That should make everybody feel very comfortable. So look at the base score. This is a measure definition. Now this I simply exported to Excel from the CMS website and then slapped it on a slide. But looking at the first one, the e-prescribing, that's at least 1 permissible prescription written by, the rest of it is essentially written by a doc that queries drug formula and transmits electronically. Okay, so everybody in the room that's been doing meaningful use transmits prescriptions electronically, by and large. I don't know about the various versions of EHR in the group, but many of them do have the ability to hit SureScripts, which can track and store payer formulary data. So that means for a prescription, 1 prescription by 1 clinician in SERPA through 1 EHR has to be able to hit SureScripts or another third-party clearinghouse, pull formulary information, display that in your EHR. I know both Cerner and Epic have that capability. So that's required for a base score. Next is the health information exchange. That, though it reads a little bit different, I've gone into this with our experts here at some depth and checked out some of the CMS help chat information about this. That is meant to be defined exactly like the meaningful use HIE definition was. So that means that an eligible clinician is sending a summary of care record, a CCD, and electronically transmitting it to an HIE. I understand SERPA is involved in working with an HIE. You're pushing CCDs now. That should be done. Providing patient access. 1 patient has access to view their record online and download and send it to to another body. So that's basically portal access or access to the HIE. I'm understanding most are doing that. Then security risk analysis. You'll see a bunch of federal legislative language there. That's basically the meaningful use and HIPAA security analysis. And I know those are defined somewhat different, but it's the same concept as the HIPAA security analysis and risk assessment we did back, what, 7, 8, 10 years ago. That's basically, can you attest yes, no at each site that you've done a clinic, a security risk analysis or review. And that's an administrative exercise for clinic managers. Get the definition, work with SERPA, figure out what the form is to attest you've done it, what evidence SERPA and you all want to store on record. And we're supposed to store all the data we transmit for 7 years, but you attest it and SERPA tests for you and it's done. So those are all required for the base score, all or nothing. You do all 4 of those, including the 2 that say at least 1 patient, at least 1 prescription, and you get your automatic 50 points for the base score. Now notice the next column on the right, performance score, 2 of those not only count the health information and the provide patient access, they not only count for your base score, they also count for your performance score. So you get to double dip. So we want to focus in on those 2 and actually do well on them. The provide patient access to the portal, that's been a meaningful use measure or a PQRS measure. We've been focusing on it. And the HIE is already hooked up electronically. So we ought to be able to do well on those. So it's nice to be able to double dip. That rarely happens with Medicare programs. So that's the base score. Let's move on and look at the performance score. Performance score, again, I'm focusing on the 2017 ACI transition measures. That set has 6 possible performance measures. The other set, the more challenging set, the set that some of our EHRs probably can't do, have up to 9 measures. So the set we're focusing on has 60 points possible. So you're hearing that there's 50 points in base, 60 points possible in performance. That's 110 points so far. This is only scored out of 100. And that's about providing patient access and health information exchange. Both of those are up to 20 points, so up to double credit. The ones that are new are provide patient-specific education. That's been a PQRS measure. That's the EHR suggested education based on diagnoses or problems in the EHR, and EHR does it a bit different, but most of them do it. Then it's a view, download, transmit. And then there's immunization registry reporting. So I've mentioned the 2 that are worth double credit, up to 20 points. 3 of them, including the patient-specific education, the view, download, transmit, and the med reconciliation, again, a very classic PQRS measure, though it's changed slightly. Those are each up to 10 points. And then notice the immunization registry reporting. That one is also a test. If you simply attest that you push to the state immunization registry, you get your 10 points. If you don't do it and you say no, you get 0 points for that performance score. So let's look at the specifications a bit more closely. So for the immunization registry, this is at the, each provider's not using a different EHR. Each clinic has an EHR, so it's at the EHR clinic level. Are you, in active engagement with the public health agency or registry submitting immunization data? Or if your EHR can do it, it's usually you simply turn it on or you don't, and that's where you are, and that's a 0 or 10%. There's a level of detail that you all have probably thought of, which is, okay, and I'm making these numbers up, say there's 14 clinic participants, organizations in SERPA, say, 8 of them can do this through your EHR and 6 of them can't. I think that's still a yes, but that's going to have to get into the specifications even a layer deeper than this that I've not yet seen detailed. Then med reconciliation. This is for, and actually it is the very same definition that PQRS used. It's of patients who had a transition of care from the acute hospital back to primary care, what % of those had active medication reconciliation done? So most of your clinics ought to have workflow that are already doing that fairly reliably. Patient-specific education, use clinically relevant information from your EHR. It helps you identify what's an appropriate education piece for the patient, and then provide it. Love the next phrase, to at least 1 unique patient seen by the doctor. So again, a very low threshold for that. and that scaled 0 to 10 points based on performance. Okay, so that's the first three. Let's look at the next. Secure measuring or messaging. For one patient, secure messaging is sent. That's the other quadrant. The specialized registry, that's for a bonus. View, download, transmit is for in the performance period, can the patient view or download their health information? Again, that's a performance. So those 6 performance options are fairly understandable, and the specifications are available, which is what I'm showing you now. Many of you physicians being detail-oriented are going to say, okay, I get the med reconciliation detail, right? Patient leaves the hospital, they come to us, we need to reconcile their medications. I want to know specifically inside the EHR at the data level, what do you have to do to meet the measure and what does the machine spit out, right? That is generally, just like it was for PQRS, that is generally engineered by the EHR vendor, and you don't really ever see the programming, the machine language, the programming gobbledygook that says this is how it works. Usually when you ask about the details for exactly how does this work with my EHR, which is XYZ, you'll get a workflow chart that the vendor says, this report is built, we've validated it functions as it should, to have a patient count in the numerator, here's how patients count in the denominator, and this is what you have to do inside your EHR for the patient to trigger the numerator and count, or to be seen as met. And that is something the EHR companies provide, and it will be different for each EHR. Lastly, the third bucket is the bonus score. So 50 points base, up to 60 points performance, and now you see on the right-hand side for the 2017 transition measure set, up to 15 bonus points. If you report electronically, directly from your EHR, or from the HIE possibly, to some other clinical data or public health registry. So maybe you've got it set up so positive chlamydias and gonorrheas directly hit a state public health database. Okay, that's possible. If you do that, that's worth another 5%. I don't know if within each of your circumstances and within Nebraska if that is possible or not. My group is not aware of, in Oklahoma, any other state-wide, essentially specialized registry or syndrome surveillance reporting besides an immunization registry that we could report to. Last, worth 10%, and this is a dollar sign here. This is report certain improvement activities using CERT. Okay, so this is advancing care information. We're not paying attention to improvement activities. We get our automatic 20% for that, right? That's great. Well, if you focus on an improvement activity that involves certified EHR technology, which is very much what we're paying attention to here for ACI, you can get up to 10% bonus points. So that leads to an obvious, as we work together to improve our care, and as we work together to do this ACI stuff, let's find one of those activities from the clinical performance improvement activity list that is focused on EHR that we're going to have to do anyway, do that and gather some data about it, gather some process about it, and provide that, and we get 10% bonus points for stuff you're going to do anyway. Here's an example of what types of things qualify. There's a list that you can link to from CMS QPP website, like I mentioned. So this is an example for a improvement activity involving CERT, which qualifies for the Advancing Care Information Performance bonus. And this one is about expanded practice access. Provide 24/7 access to the certified EHR. For an improvement activity, that's highly weighted. We don't care. It is related to advancing care information, however, and doing that activity, proving you provide 24/7 access for your patients to your EHR, whether that's maintained within the group or you share a call with other groups, those groups have access to the EHR. If you do that activity, prove you have that access as you work through that measure set, then you get 10 bonus points. For many or for all of SERPA, that may already be in place, because that's a fairly fundamental quality and outcome way to set up performance coverage. Okay, so each of those performance measures and the bonus measure would have a rate. They'll have a numerator denominator. So each individual would have, your EHR would spit out the numerator denominator. It rolls up to the site, or each individual rolls all the way up to the SERPA tax ID number. So your numerators and denominators are big for every one of those 6 measures and the bonus. Then you say, okay, you just do the math. Numerator divided by denominator says we did 85% on each of those. Each individual performance, say you're doing the one on messaging or access, you say, okay, our performance rate on this one was 85%. Out of 10 points, I see that performance rate of 81 to 90 gets us a 9. So out of this 0 to 10 points on this one performance measure, we got 9 points. You would then add up the remainder of the performance measures you chose to do, add up the points. Remember, there's up to 60 possible for performance, and that would be your performance points. Then when you roll it together, your base score is 50. Your performance measures here, since we're doing the 2017 transition measures, is not 90, it's up to 60. Then you have any bonus points. If you did a performance activity that qualifies for the church bonus, that's scaled up to 10 points. And 50 plus 60 plus a possible 15 gets you 125% bonus points, or 125 points possible. It's capped at 100. So if your total score is above 125, you got 100% automatically. Otherwise, you divide it by 100, and that's your score for ACI. Now, say you've got 95 points out of the 100. Right? You tried for all 125. You didn't get the bonuses for whatever reason. You got 50 points, and out of the possible 60 for the performance measures, you got 45 points. So 95 points total. How that adds up is, my example I did was 90%. Say you got 90 points. We know that ACI is 30% of your composite. So your 90 points, 90% times 0.3 means this is 27 points rolled up for your composite score. To give you another more table-based example, so here I've got 2 different performance measures for Dr. A through E. Each one has a certain number of patients. The EHR generates this data. You see for secure messaging, the docs on the right or on the left add up to 86%, which is 9 points using the scale I showed you earlier. For performance measure 1, you'd record 9 points. It's worth 10. For performance measure number 2, the view down transmit, you see the group adds up to 7, adds up to 61%. That was 60 to 69, gives you a 7 points. You add up 7 points. The group chose to do all 6 performance measures. You add up your individual performance, each of them, so you total 44 points for the performance measures. The base is 50 points because you did them all. Remember the very low threshold for at least half of those. Base score 50. Your performance score was 44. That adds up to 94 possible. Say that gives you an 85% overall, and times the 30% ACI contributes to your composite score. That gives you 25.5 points out of the possible 30. So that's how it adds up for your composite score. So we got 15 minutes left. Let's roll on to some conclusions and some recommendations for SERPA, and that should give us some time to answer questions. I know that is a level of detail that a provider who is highly focused, highly efficient, and extremely good about taking care of patients may not want. It is, however, the world we live in, and I'm about helping each of you and SERPA succeed to the highest degree you can, and that's essentially what the MSSP is about to start with. So as we take this on, I just encourage everybody to keep perspective, and the same set of circumstances. It's a bit of a data burden. Some of it, the quality you've already been doing. The ACI is understandable. Everybody on the call was a master of the Krebs cycle at one point in time, so I believe we all can master this. It just does take some focus. And the opportunity, if you're the guy in the boat, the opportunity is it has the potential, as SERPA's quality continues to go from good to excellent or excellent to fantastic, as we do our ACI, the group may have the potential for 3% performance update this year and 3.2% performance update next year. And if you do the math, you figure out what your performance, I mean, if a clinic has $100,000 in billing for Medicare and your bonus, 3% bonus next year means it's $103,000, and your 4% bonus the year after means you get up to $108,000, it's pretty quick to see how those yearly updates make a big difference in financing. So let's look at your actual data. I appreciate Jolene and Dale and SERPA sending this to me under our terms of agreement and confidentiality, and I'm really impressed. This is a really nice chart. I understand this has been provided to the group, I think, every 6 months, Jolene said. So this is all the various quality measures with all the various programs you all are involved in and who tracks what measure. Okay, that is important as you build process. So the ACO quality measures are set. They are what they are. You see what our MIPS measures. You see what your Blue Cross Blue Shield data currently and possibly the 17-18 tentative contract is tracking. So it lets you really look across the columns, pick the efforts and initiatives where you meet the most imperatives at one time. Just efficient practice management. Looking at your quality, I am very, very impressed. Group is at the 90th percentile. This is your actual GPRO submission. You're at the 90th percentile for a high number of these measures. The ones where you still have opportunity, I circled. So the BMI follow-up, screening and follow-up plan, BMI is automatic. It's somehow making discrete that you have a follow-up plan in the chart, which is hard, so you have a performance opportunity there. That may or may not be one to focus on. The way we've been able to build that in Cerner is essentially we made a checkbox. It drops like a dummy order with zero charge attached to it. And that's how we report it. That's not a great workflow, but it does work, and the groups that do that type of workflow, typically you can get this to 97th percentile pretty reliably. Breast cancer and hypertension, groups been working on both of those. Both are in the 70th percentile as well as colorectal cancer screening. That is strong performance. It's just not the 89th percentile like the rest of your performance. So great job. I'm impressed with those numbers. And then here's a different look. This is the Blue Cross Blue Shield contract quality measures. You got your points for readmissions, for ED visits, for breast cancer screening. I think it's interesting that for the MSSP data, if you look at your breast cancer screening, you're at the 70th percentile. For your Blue Cross data, it says you're actually already, you're at 80 percentile, which is already above the NCQA, HEDIS 90th percentile. So it's interesting that there seems to be some variation in your population there. You have opportunity where you didn't get points is in colorectal. That lines up with your MSSP data. Controlling hypertension, have opportunity there, and then monitoring persistent medication use is an opportunity. So how do you get additional points? This is a good exploration. So you see for the colorectal screening, you get another 661 patients, you'll hit the 75th percent, and I'm assuming that gets you 1 point. If you get another 1,000 patients, so that's, 6,000 patients in your denominator, 3,000 patients were met, so you're just a bit just about 50%. You need another 1,000 patients to meet the 90th percentile. That's likely not a one-year goal. That's a multi-year goal. But 661 seems doable to pick up a point. Controlling hypertension. Likewise, right? I wonder if there's a data problem with Blue Cross. That says you have 1,800 patients, 1,893 patients, only 21 of whom are meeting the measure. That doesn't smell right, so I suspect you all have already gotten into that with Blue Cross. I'd want to see their data to see what they say about that. The monitoring persistent medication, look at your digoxin. You only have, what, 10 patients in the measure. You need one more patient to meet the 75th percentile. I don't know if this is truly, it's hard to believe there's only 10 digoxin patients in all of SERPA. That's what this seems to suggest to me, if that data is correct. Find those 3 patients and reach out to them. So this is work the list and figure out where your opportunities are. For things like monitoring medication for your ACE ARBs and your diuretics, standard accepted medical therapy is that all of those patients have a BMP once a year. So maybe each group can work with your informatics or your EHR support and make that CERTA calls it a health maintenance expectation. EPIC has a different term. Everybody does it a bit differently, but basically that is an internal tracking. It would pop up once a year and tell you something was due if it wasn't automatically met. So there's a way to kind of automate reminders for that. So what are the next steps? Looking at your quality measures, which are already quite strong. Look at your quality performance measures, agree on which you're going to actively improve, and though you have the biggest opportunity in BMI assessment and plan, that workflow is challenging, and it requires each EHR do a workaround, since that rarely can be automated. So you might look at that. My recommendations to the group is that you focus on breast cancer screening, colorectal screening, hypertension control, and diabetes eye exam. You had opportunity. Each of those are standard, high-quality care, realizing that your data reflects both two things. It reflects both quality of care, and it reflects the data the EHR knows. So there are plenty of patients for whom they had a scope, and you just don't have the document. Your care is great. We just haven't fed the information in. Same with diabetic eye exams. So we just have to accept the data is what the data is. Agree patients have had appropriate care. It's an additional, it's an additional part of our work for our full team of getting the data into the EHR in a way that basically means source documentation. You have to have the report typically for that to be met. So what are the next steps? So that's your quality perspective. For your ACO quality measures, those are the ones I would focus on. Your diabetes composite score is already pretty darn good, and that's a combination of the inverse measure A1C controlled and your diabetic eye exams. However, I did notice it had gone down something like 4% in the last year, and your diabetes eye data by itself wasn't as strong. So focusing on that should maintain your composite measure and help increase it. Next steps for ACI is, first of all, at the clinic and SERPA leadership level, agree on which technology set you're going to use. My strong recommendation, for reasons we've discussed, is the 2017 transition objectives. The next, really need to agree on an overall strategy. Since everybody on the call will be reporting together in one big bucket through SERPA, we need to agree on a strategy. Everybody needs to be in the boat, holding your oar, rowing the same direction, or clearly scores will not be as optimal as they could. So 3 recommendations is that everybody work in concert on the same performance measures. If everybody agrees that the bonus for electronically submitting data for some other outside registry isn't possible in Nebraska, that's up front, it's agreed to, nobody spends any effort on that. If everybody agrees we're going to try to maximize our 2 base measures, which allow up to 20 double points for performance measures, we're going to try to maximize, get all 20 points on that. Everybody rows the same direction on the same measures. Next, as opposed to the strategy I just mentioned as an example, I would recommend the group pull the oars together on all 6 of those performance measures. I think given that, it should be fairly easy to get your 100% and to get, or at least possible, easily possible to get your 100%, to get all all 100 points, which would get you, with the 30% that contributes to your composite, it gets you 30 full points for that. So back up to the 5,000 foot level, there's no cost. You get an automatic 20 for the practice improvement activities because you're in an MSSP. So you start with 20. You get all 30 for ACI, several of them with very low thresholds for this year. You're at 50. We just looked at your quality, eyeballing your quality scores. I cannot prove any of this, but I think your quality scores to my eye right now get you something like a above 80% overall for that 50 points. So suddenly you're looking at 20 automatic plus 30 for ACI, you do great. Then out of the 50 for quality, if you're somewhere in the like 80% level as a group, that gets you whatever 80% of 50 is, call it 40 points. You're at a 90 for your composite score, and that is fantastic performance. Lastly, my last recommendation for ACI is the group does agree to try to get your bonus points. Focus on an improvement activity you're going to do anyway involving the EHR and claim the bonus points. So lastly, next steps for analytics and workflow, so that every clinic member of SERPA ought to work towards a monthly dashboard involving your quality and ACI reporting. So each EHR is going to have to spit out the data to give to SERPA. So that means that it is at least possible, I know it's how we do it here, that you can do monthly by provider your quality and ACI dashboard. Understand this is April, build time, etc. So do what you can to work towards it. Doctors are remarkably responsive to data. Given understandable, compelling data tied to workflow in your office, we can do amazing things, usually within the flow of care. So that'd be a best practice to work towards. And finally, really look at implementing at each clinic level, pre-visit planning and rooming, and advanced rooming, actively manage every patient leaving the hospital for sure, because you have to do medication reconciliation for them. But again, this is an MSSP. Shared savings is about cost. The vast majority of your cost is nothing we do in the office. It's about patients laying in hospital or ED beds. And so that goes back to advanced. You want to actively manage every patient leaving the hospital. Lastly, conduct post-hospital follow-up. Get every one of those patients in before 7 days. And if you do, for gosh sake, build TCM for it, transition care management. Data from multiple health systems show something like 30% of readmissions happen before day 7. So if we approach this in more of an old-fashioned perspective, is we'll look at every discharge and kind of decide how sick they are, and when, we'll try to get them in by 2 weeks. You've already given up your ability to manage 30 or 40% of your readmissions. And if you get them in by day 7, you have the option to build a higher level transition care management code, 99496, if the patient qualifies. So that has 50% higher revenue than doing that patient in the office and billing a 99214 as is typical. Finally, know the list, love the list, and work the list. And that's talking about the list of patients missing mammograms, list of patients missing colorectal screening, diabetic eye exams, etc. How you operationalize that is somehow print the list once a month and then divide it up. And if your group's missing 100 colonoscopies, you have 100 patients, you split the work up among the office, it's good management, and the staff try to contact some small portion of that each day or each week. Each day you call 3 patients missing mammograms, and you gradually get them worked in and dealt with. This is an example that I won't belabor. It just puts up how a pre-visit planning form might work. This involves starting the day before the visit, 2 days before the visit, morning before the visit, depending on your workflow. The stuff you're pushing on together, you find for every patient coming in today. It doesn't matter if they're coming in for a sore throat. We're all pulling on colonoscopies and breast cancer screening and digoxin surveillance, etc. So you know that about everybody who comes in, and you deal with it for everybody who comes in regardless of reason. So clearly that has workflow implications, and there are days that we understand where you've got 40 patients crammed into 20 appointments, and sometimes you let things drop. But it is, in general, to really succeed at this endeavor, to prove the amazing care you're providing, and to make the care you're providing even more amazing than it is, it does take moving these efforts into our usual workflow every visit, every day, so the act of providing care gets you what you need. It's not some special effort responding to a list. That's important, but that can't be the central focus to really succeed at a high level. And with doing that, the group will have exquisite teamwork, rowing the boat ahead to an amazing composite score, and you will have become the winged cheetah of primary care. I appreciate your time. Be happy to take questions for anybody that can stick around. It was a pleasure meeting most of you 6 weeks ago, and I look forward to next month. Thank you very much.
Are there any questions from anybody? Quiet group.
Sounds like no.
If not, we will be doing another webinar next month, and so we'll have Dr. Mills presenting on that one also. If you have other questions, you can always take and write them and send them to us, and we'll get them to Dr. Mills. I'm sure he would be willing to answer them, right?
And a reminder about attending.
Absolutely. Happy to do it.
Okay. The other thing is that if you have physicians that are there and they want CME, please get their names to Dr. Michaels. So great presentation. We appreciate your time, Dr. Mills.
Hey,
Thanks for inviting
Jolene, this is Craig over at Plum Creek. Is there any way we can get the slides over on Basecamp?
They will.
When Dr. Mills sends those to me, I'll send them. We'll also have the full recorded session out on Basecamp also.
Thank you.
You bet.
If the providers do watch it on maybe a different time, can they still get CME hours for this?
Yes, they can.
They have to
All right,
send
thank you.
us a note that they did it.
You have to send a note that they did though.
Okay, definitely.
Okay, we will be scheduling one for next in May, and we'll be getting that information out to you. Thank you all for attending.
Thank you. Okay.